Now we move to the discussion. I would ask the audience to pose questions to our fantastic speakers. We have one question from the audience. I think that more or less Professor Bougain has talked about this, and is about if GMA would also work in Crohn's disease. You have told us that we have a randomized control trial. Is there any evidence in addition to this randomized control trial? What do you think about?
Yes, this is a problem, I think, of lots of studies on GMA. We have just cohort studies, so we know that we have about 30 to 40% of response in Crohn's disease. And when we build a randomized control trial, we just want to know if it's better than other therapies, and particularly the placebo arm. So I think I don't have in my mind other trial. I think this is the only trial we have on Crohn's disease. However, you can see that at the end of the trial, you can assess only 40 patients in one group and 20 patients in one group. So it's just underpowered to have any conclusion. And when you look at trial actually on the biological or JAK inhibitor, you have about 600 patients in each arm. So this is why I think we don't have this statistical power to put any conclusion in this trial. But the real life and the core study show clear beneficial effect of GMA.
Yorgos and Ruben, is there any rationale to use neutrophil target device or treatment for Crohn's disease from a basic point of view?
Do you want to start, Yorgos?
Sure, yeah. I think the question of is it helpful in Crohn's disease will eventually be answered by clinical trials. There is no other way. However, if we're talking about the theoretical basis, I think yes, there is a theoretical basis. Yes, neutrophils are important in Crohn's disease as they are in ulcerative colitis, especially in people with ulcerations and acute damage to the intestinal wall. And we should not also forget that it is not, Adacolumn is not only about neutrophil infiltration. There are many other ways and many other effects of this methodology, which fit very well into the pathogenetic scheme of Crohn's disease as well. So yes, there is a basis for using it also in Crohn's disease and in other inflammatory conditions as well.
Yeah, I agree. I mean, I think that just talking from an immunology point of view, I think that even though IBDs are mainly sustained by T cells and we will focus very much on T cells, it's becoming more and more clear that neutrophils and all the innate pool of cells, it's more and more important. And I guess that from that point of view, it makes sense always to try and reduce or downregulate these populations in terms of inflammation.
We have another question from the audience. This is for the clinicals. Dimitrios Christodoulou is asking, is Adacyte suitable for patients with resistant and steroid-dependent rectosigmoiditis? So this is limited to the rectum or the rectosigmoid.
Yes, I don't have any study on this point, especially, but I think that we just separate proctitis to left side and pancolitis, but in trial actually. But I think it's the response of the rectum is similar to the other, and we saw, for example, that we had some cohort study on the TNF adjunct in proctitis, and finally the response rate and the rate of remission, the rate of mucosal healing is the same when you treat a proctitis and or as compared to left side open colitis. So yes, you can treat also proctitis, and actually in France we have the same algorithm to treat proctitis or extended colitis. So similar.
Okay, Ruben, you told us that there is a gap in research, mainly in the trafficking of immune cells. So this maybe could give an answer for this partial or segmental colitis. Do you think that we will have data, or there is any preliminary data on cell trafficking regarding the different segments of the colon?
Yeah, I think it's well established that the expression of oxidation molecules, selectives, and also integrins is completely different in different parts of colon, and how these cell homing markers affect to get the cells there, and where the inflammatory response is it's more evident. It's going to make a difference always in being effective or ineffective in a treatment. In the case of Crohn's, for instance, when there is areas affected and areas that are not affected, this is going to be very, very important in terms of being efficient. In terms of colitis, I think that this newly described population of non-classical monocytes that express this alpha-4 beta-7 integrin, this will be very cool if we can demonstrate that we are able to get these circulating monocytes out of the equation. It will be very, very nice.
Okay. I have a question for the basic ones, so Ruben and Yorgos. Why we don't have any drug targeting neutrophils? Why we don't have any monoclonal antibody targeting neutrophils? We have many antibodies targeting some cytokines, or even targeting the trafficking of lymphocytes, but there's no drug targeting neutrophils. We have a device that's GMA. But why is there not? Which are the expected dangers of targeting neutrophils by a drug?
Did I start?
Well, whatever. I think neutrophils, it's such an important immune population. I mean, it's neutrophils are also called the professional phagocytic cells, and I think they are so important and have so much beneficial effects on inflammation that maybe blocking the complete function of neutrophils would have detrimental effects on the immune response. I don't know if you, Georges, want to add something else.
I completely agree. There was an old immunological dogma, if I remember well, which said, do not touch neutrophils.
Right.
Because it was supposed that you're going to become completely defenseless against infections. And I think the safety profile that Professor Bourgen showed us before is exactly a proof of the opposite, that you can modulate the function of neutrophils without putting your patient in any great danger. Apart from that, I think there was a simplification of the pathogenesis of IBD for many years. Immunologists thought that everything is about T lymphocytes, the Th1 versus Th2 paradigm and all these things, which eventually through time they were proved all wrong. And in fact, the CD4 lymphocytes were considered the orchestrators that subsequently would induce the innate immunity responses, whereas now we know that it's exactly the opposite, that the innate cells are the ones who dictate the adaptive immunity which way to go. So as the paradigm changes, I think the immunological targets will change, and we will see therapies also which will target the neutrophils. I think in other specialties of medicine, they already try to block some effects of the neutrophils.
At least we can say that GMA is a friendly way to target neutrophils without any danger, at least what we have seen. We have many questions from the audience. Now for Professor Bougain, which is the percentage of patients who must stop the treatment because of venous accesses?
Oh, I cannot have any answer to that. I'm sorry. So I should go back to the randomized control trial, but I think it's not so much patients because finally we just don't introduce GMA in patients without venous access. So this is just a little bit different, and usually we stop GMA not because we don't. I never had to stop GMA because of venous access. I don't start one GMA in one patient who don't have any venous access, and we usually just stop GMA because of non-response or loss of response. But I never had this issue actually.
I fully agree with you. At least in our experience in Spain, I think that venous accesses are a limitation for starting GMA, not for maintaining or for stopping GMA once it has been started. So, and this occurs more or less in 10 to 20% of the patients. But however, there is a solution for those patients who have no good peripheral venous accesses. So we could also place a central line. Which is your experience with GMA with central lines, Guillaume?
I don't like central lines. I never use it because we use it in the past sometimes for infliximab infusion, for example, or for parenteral nutrition. But we had, I think this is a safe procedure. You don't have to increase any complication because of the procedure, and you can have some clot, some infection when you put a central line. So, and that's why I never use a central line for GMA. But this is my point of view.
Okay, but this is also an option to place.
Yes, of course.
And there is some experience with that. We have more questions from the audience. I think that this could be for all of you. Is about combo therapy. So, do you think that initially combo therapy, infliximab or other, even vedolizumab plus GMA would be more effective than GMA alone? And I add a supplementary question of this, is which would be your ideal combination with GMA? Yorgos.
Yes.
The first one.
Okay.
He talked about combination therapy, so he should start.
Okay. So my point of view is that because combination therapies are proposed more and more in clinical practice, I think the critical point would be to combine two therapies that have different modes of action. So you should not keep on aiming at one target. So let's say, in my mind, let's say combining anti-TNF with anti-interleukin 23 or 12, it doesn't make a lot of immunological sense because TNF is a downstream effector of the of the Th17 pathway anyways. So I would try to combine different things. And this is the good thing about Adacolumn, that it has a unique mode of action. It removes the cells of the innate immunity alongside all the other effects that it has. So if you ask me to make a guess, I would say that I put my money on a combination of Adacolumn with vedolizumab because it affects two different populations: the innate immunity population on the one hand, the lymphocytes on the other. But again, as that German study that I showed you indicated, things are not exactly as we have them in our minds. In clinical practice, you see different things from what you expect to see.
Any additional comments from the panel?
Yeah, I agree. I think that it would be like the best combination from the immunological point of view because, as he said, TNF is so so early in all this inflammatory cascade that it's going to affect all the adaptive immune response. So it seems more interesting to also try and kind of block this migration of cells or these T cells using this anti-integrin rather than using something that in fact blocks products produced by monocytes, because all anti-TNFs, I12, I23, I6, and so on, they all block products that are produced by monocytes.
There's another question from the audience. This is for Guillaume or for Giorgos. How long do you consider for maintenance schedule? Every 4 weeks always, or can we use other treatment schedules for maintenance therapy with GMA? What is the evidence for that?
We don't have lots of evidence. So actually, we had this first patient, and we don't know what to do. So we put the patient every 4 weeks for maintenance therapy. But she relapsed. Actually, what we try to do is just to delay progressively the time between sessions. So we start after the induction with weekly session to put the patient every other weeks, and if it works, we just delay a little bit more to every 3 weeks and 4 weeks to GMA. So this is our practice, because I think we don't know which maintenance to do in this patient. So my feeling is that every 2 weeks is a good maintenance schedule.
Giorgos, from an hypothetical point of view, should it be better to establish the schedule driven by fecal calprotectin, so to target fecal calprotectin levels because of the mechanism of action of GMA, for instance, for maintenance schedules?
Yeah, I think that's a very excellent point. Of course, I don't know if there are any studies that associate the effect of GMA with fecal calprotectin. I'm not sure I've seen any of those. So in theory, yes, a treatment that targets neutrophils, it makes sense that it can be judged by the product of neutrophils. But I'm not sure if there are no studies. We have to wait and see if there is a strict correlation. On the other hand, fecal calprotectin it can be used in many different scenarios. So I would say yes.
There's another question from the audience. Does it make sense to use GMA to reduce TNF burden, to bring it to control with infliximab? So I understand that first using GMA to reduce the TNF burden, and then or concomitantly at the beginning of anti-TNF agents. What's your opinion?
It's a tough question.
Yeah.
Difficult to answer.
Yeah, I can comment on this. I'm not sure that it's going to work that way, because actually this proposes that we use two anti-TNF therapies one after the other. I don't think that it works like that in clinical practice. I don't think that people who don't respond to anti-TNF, they don't respond because there is too much TNF and it is not enough infliximab to block it. I think it's rather a different mechanism of disease over there. So I'm not sure if this will work, or if combining Adacolumn with infliximab, the effect would be on TNF on both sides. There may be different effects which will have a synergy. That I can accept, but if this is the sequence of events, I don't think so.
Mm-hmm. I have another question for basics. You told about the effect of of GMA on the levels of IL-10. Is there any evidence for other drugs in IBD that achieve the increase in IL-10 levels? Because this is quite an indirect effect of GMA. So is there any other drug used in IBD that achieves also this increase in IL-10?
Yes, I think actually pretty much of them, all of them that dedicated to decrease this pro-inflammatory burden are indirectly increasing IL-10, not only IL-10, but also the levels of other anti-inflammatory molecules. The key point here is always try to get this balance in the inflammatory response, and whenever we are downregulating the pro-inflammatory, the excessive pro-inflammatory response, we are somehow making cells to produce IL-10 and other anti-inflammatory molecules. So I would say not directly, but just indirectly with any molecule directed against pro-inflammatory molecules, we would be inducing IL-10.
Okay. Still more questions coming from the audience. Actually, in severe colitis, there is a loss of anti-TNF in the heavily inflamed colon, and that may be the reason for primary failure and reasoning for increasing infliximab doses or shorter intervals. That's a comment on the previous answer, I guess. There is a question about are there any eco recommendations for GMA, Guillaume?
No.
No.
There is no recommendation for GMA actually, and but I don't know for the next one and the next step if GMA will be inserted in the future. I don't know. Perhaps you have the answer.
Okay, so we must produce more evidence maybe for including GMA in the ECHO guidelines, of course. My last question, if there is no other questions from the audience, is regarding this lack of evidence, or there is just a few evidence that GMA works, but when we are going to randomized controlled trials, there are only a few randomized controlled trials, but we have some data suggesting that maybe, especially in the Spanish one, that GMA works, but maybe a question of sample size did not allow to achieve robust conclusions. So, which would be your ideal trial for GMA? If other site contact you and ask you, please design a trial for the use of GMA in UC. Which will be your design? Which will be your comparative arm?
It's tough. Yes, it's very tough. The GOLD trial is a randomized control trial. So I will say I will probably build another randomized control trial. Why? Because if even we don't have randomized control trial with poor randomized control trial, we can put them together in a meta-analysis and with no heterogeneity, and so we will have some data with the multiplication of this randomized control trial. And actually, but this is my mind, I think we have a big ethical issue with randomized control trial against placebo. When you have an IBD patient who still had 2 or 3 lines of biologics, I think it's not ethical to use a placebo arm. So I don't know, perhaps, but this is a good trial. I don't have any issue. I will say I will put a randomized control trial in UC, and we'll try to to have more inclusion than the other, but it will be perhaps a little bit difficult. And but I think perhaps to increase the inclusion of patients in this trial, I would say, okay, so we'll just put the GMA in action, and we no scope procedure, just fecal calprotectin, and we follow you, and we will see whether we can use another endpoint, for example, the decrease of fecal calprotectin as the primary endpoint, and I think we will have efficacy, because when we start GMA, in my practice, and this is what we saw in randomized in cohort study, the response is very quick. This is usually within the month of the GMA. So I will perhaps do that, a randomized control trial, an easy randomized control trial without scope procedure, without all these red things around the randomized control trial, and just a follow-up on fecal calprotectin.
But against placebo?
And I will try to avoid this question, but the problem is that if you compare the DMA to another treatment, you have to increase a lot the number of patients just to be comparable. So I think it's actually not possible. So it will probably against either placebo or either steroid, whether you can decrease steroid or not, perhaps. But yes, this is, I think, a big issue in IBD trial, actually.
Yorgos?
Well, it's difficult to say because also Adacolumn is not used in Greece, so there is no clinical experience in my country. But again, from the theoretical point of view, in my mind, Adacolumn fits well when there is the beginning of an acute flare of the disease. So I would see it as a very useful adjunct in patients who are in a remission, and somehow they start losing or they start increasing in fecal calprotectin. So then I would like to see if adding Adacolumn at that point would save the remission and bring the things back to normal.
Okay.
And you, Jenny, what do you do?
Well, I think that maybe there are two possible designs. I love the one that Yorgos proposes. So to use it in patients with high fecal calprotectins but in clinical remission, I think that this is a good point. Or even in patients at disease onset, so using GMA together with steroids as compared to steroids alone. I think that this could be a good design. And also, I think that the rate of clinical remission at 1 year in most of biological therapies is still too low. So it's about 30%. So 2/3 of the patients starting the biological, even in first line biological therapies, are have a very low efficacy. So maybe I would like to have a randomized control trial with an add-on strategy. So GMA plus a biological, and this I would ask the basics to choose which is the better biologic to combine with GMA against monotherapy with the biological alone. There's a last question from the audience. We have the last minute. This is the last minute question. So I want to ask you, this is a clinical question. This is treatment with GMA twice per week more effective in severe cases? How long should we continue intensive treatment in case of good response?
Yes, the response is in the meta-analysis, the recent meta-analysis, and we had actually some Japanese data who compare twice weekly to once weekly, and when we put together the data, there will a little effect of twice weekly GMA. So it's perhaps more effective, but I think that actually we should stay on 1 weekly because the effect is not very high. So for me, in my practice, I just do weekly sessions of GMA, even if the patient is severe.
Okay, we are on time. I want to thank all the speakers for their excellent talks, and also I want to thank the audience for being so actively asking questions. Many of the audience have congratulated for your talks and the discussion that we have had after. So thank you very much to all of you, and well, we have to use GMA and have more experience on that. Thank you very much.
Thank you.
Bye.
Bye.